Tell me about, let's go back to the elderly for a second. What about IRD ixazomib with lenalidomide dexamethasone in that setting? Have you had experience with that?
We've certainly used ixazomib in patients, and I do think it's a perfect drug for the older patient population. So IRD, which is going to be the Tourmaline trial in the upfront setting, will hopefully be read out sometime again next year. And, you know, ixazomib, as all of you know, is a weekly drug, oral drug, extremely well tolerated, and they're seeing very high response rates with that as well.
Cristina, used ixazomib at all in the elderly group yet, or?
Yeah, occasionally, you know, it's difficult, unfortunately, outside of a clinical trial to justify it up front. So, you know, for patients, for instance, you start the RVD light, and if you have toxicity, it makes sense to substitute the bortezomib with ixazomib, which is relatively well tolerated.
So your group, Bob, at this meeting is talking about using ixazomib in the maintenance setting. Do you want to give us a little update on what you're doing there?
Sure. We are reporting a couple of trials, actually, one with ixazomib and lenalidomide, which is a little bit more mature. And we've done that as a post-transplant maintenance. The safety is excellent. The tolerability is very good. The 2-year progression-free survival is a little bit north of 80%, which is positive. And then we also have a trial of lenalidomide with elotuzumab, which isn't finished enrolling yet, so the data are not quite that mature, but actually look more like an 85% 2-year progression-free survival. And on that trial, the only people so far who have progressed are folks with high-risk disease. So those may be applicable also to the older patients. The one other thing I'd say briefly about the older patient population, right now we think that a proteasome inhibitor and an IMiD combo is the best, so certainly RVD light or Ixa-Len-Dex is great. But it'll be very interesting to see the antibody data when we see Len-Elo or Len-Dara. And before we rush to do 4 drugs in older patients, where I think it's going to be tougher because they're not going to tolerate them as well, I think the next question is, should we do an IMiD and a PI or an IMiD and an antibody in the older patients?
Right. So let's talk about maintenance a little bit. And I'll let anybody answer this one just to be... see who hits the buzzer first. What's your strategy in maintenance today?
Post-transplant maintenance, I think distinguishing between maintenance and continuous therapy. I think Noopur already made the point that we are in an era of continuous therapy. So,
well, by continuous, what does that mean? Till relapse, or for 2 years? How long?
Until progression, really, with some form of maintenance at that point. So if you do ixazomib RD as the upfront treatment in a transplant ineligible patient, as we just talked about, you would continue either R or I as a maintenance program till the progression, which is, I think we have sufficient data from the first trial and many other data that, you know, continuing treatment in some form is...
What about long-term toxicity? Don't you worry about that just a little bit?
Absolutely. You know, the second primary malignancy signal, although it's much higher in the post-transplant maintenance setting, that is a signal. And financial toxicity, plus a lot of people have to discontinue. If you look at all the studies of maintenance that are being presented at this meeting, the discontinuation rates in the lenalidomide maintenance arms are in the 10 to 14%, which is...
So I'm going to put each of you on the spot here. Whether it's elderly or younger patient, maintenance strategy, what do you do for low risk, what do you do for high risk? 1 sentence each.
High risk, 2-drug maintenance, which is a proteasome inhibitor plus IMiD. Low risk, 1 drug, most often IMiD.
And what proteasome inhibitor?
Typically, it used to be Velcade Revlimid. Now it's more and more ixazomib Revlimid.
Noopur?
Same thing, no change.
Same thing.
Similar, I would just mention there is a large phase 3 study being presented by Sarah Bringen where they compared Len to Len with prednisone at ASH here, and the Len prednisone arm looked a little bit better. I would still be a little bit
For
concerned.
PFS, though, because I've seen that before. This is an old story with the thalidomide days.
It's true. I would still be a little bit concerned about toxicity, and what I would argue, although they didn't look at this, is that maybe if you achieve MRD negativity on len alone, go for that. But if you don't for some reason, maybe adding some kind of corticosteroid to get that last little bit out of there could be reasonable.